Hello, my name is Sergey Bedrikovetsky. I'm a member of the Royal Adelaide Hospital Colorectal Research Team, and the topic I'm presenting for you today is artificial intelligence for the diagnosis of lymph node metastasis in patients with abdominopelvic malignancy, a systematic review and meta-analysis. The current problem we're trying to solve is that there are several shortcomings regarding the detection of lymph node metastasis in CT and MRI scans. It's time-consuming, burdensome, somewhat inaccurate with 70% accuracy, and it's also an expensive process. Therefore, this problem is perfectly tailored for an AI solution. AI is split into two categories. First is the classical machine learning, which entails you extracting the features from the CT scans manually, then you input into the classifier, and this will train your algorithm to give you an output. Is the patient lymph node positive or lymph node negative? Deep learning, however, is a new technology in which it extracts and classifies the features automatically, giving a more powerful output. The aim of our review was to understand the current state of literature of AI in detection of lymph node metastasis in patients with abdominopelvic malignancies. Our methodology consisted of a search in PubMed, Embase, ScienceDirect, and IE Explorer over a 10-year period. Our inclusion criteria were English language studies, AI, CT and MRI imaging, lymph node detection, and abdominopelvic region. We excluded case reports and conference abstracts. Our initial search yielded 498 papers, and through our inclusion-exclusion criteria, we ended up with 21 papers fit for qualitative analysis and 17 papers fit for quantitative analysis. We explored the radiologist assessment for lymph node metastasis first, and divided it into surgical subspecialties. The lowest was hepatobiliary, which ended up with an area under the RACS curve of 0.633. An area under the RACS curve, the closer the value is to 0.5, the less accurate the AI algorithm is. The closer it is to 1, the more accurate the AI algorithm. The highest area under the RACS curve was in urology, with a AU-ROC-C of 0.774. Our results for Radiomics, which is the classical machine learning, Colorectal had the lowest area under the RACS curve of 0.798, and urology had the highest AU-ROC with a value of 0.895. We only found one deep learning study, which was in identifying lymph node metastasis in rectal cancer. Even though they had impressive results with an area under the RACS curve of 0.912, they used the radiologist assessment to train the algorithm. And as I previously said, the radiologist assessment is only 70% accurate. In our opinion, a better way to train your algorithm would be to use the pathologist assessment for your training. In conclusion, Radiomics models improved the diagnostic accuracy of lymphadenopathy in staging abdominopelvic malignancies in comparison with the radiologist assessment. Deep learning may further improve on this, but data is still limited. The end goal consists of having an AI algorithm that can accurately predict if a patient is lymph node positive or lymph node negative. This way we can more accurately prescribe or administer neoadjuvant chemotherapy, and those patients we believe that would have better oncological outcomes. Thank you very much.